The coronavirus pandemic has brought many challenges to healthcare, especially when it comes to breast cancer treatment. The entire breast oncology community have gone to great lengths to ensure that patients still receive the highest level of care without exposing them to any additional risk of contracting COVID-19. Today in the UK, it was announced that breast cancer referrals are down by 78%, a trend that we're seeing throughout the world. It appears that as hospitals start to open up again, they face their greatest challenge of convincing patients that it's safe to come back into hospital. I recently sat down with consultant oncoplastic breast surgeon James Harvey, consultant breast radiologist Anthony Maxwell from the Nightingale Centre in Manchester, one of the UK's largest and busiest breast centres. We talked about how they have changed and evolved their practice throughout the COVID-19 pandemic, the things that will stay in place after the pandemic is long gone, and also their advice for patients who are concerned about any changes or anything they're concerned about with regards to their breast health. If we could, from each of your perspectives, maybe just get a sense of how treatment has changed for you over the last 10, 12 weeks. Tony, if you want to kick us off as you're early in the cancer pathway, then James.
Okay, well, one of the first things that happened was that the screening programme was suspended. That wasn't a national directive, but we all felt quite strongly that it wasn't possible to continue to screen in a safe manner, given the prevalence of COVID out there and the risks to both patients and staff of cross-contamination. So we saw a big drop in referrals of new symptomatic patients to clinic. And that's been one of my main concerns all through, really, is that, what about all those patients that we're not seeing? We've had a trickle of patients coming through, but the clinics, certainly in the first 2 or 3 weeks, were really quiet. Patients were keeping well away from the GPs for entirely understandable reasons. I'm glad to say that that's now ramping back up again to something approaching normal levels. We did develop a bit of a backlog. I'm sure James will say more about the triaging, but that is now not getting any bigger at the moment. So we are getting on top of that now. So I'm pleased to say that there is some semblance of normality returning to the new patient flow.
Those cancers aren't going away, are they? They just haven't been found yet, which must be a concern.
Yeah, and of course we've got to bear in mind that although a lot of the cancers are in urgent referrals, there's a significant number of patients who are not urgently referred who also turn out to have cancer. So, it's important that we try and go back to that, trying to see everyone within 2 weeks of referral across the board as soon as we possibly can.
And James, from your point of view, how has surgery had to evolve through this crisis?
Lots of things have changed. The first thing that changed really was trying to reduce the number of patients in the unit and reduce the footfall. So we started a triage process for trying to decide which patients needed seeing urgently still within 2 weeks. And pretty much we still wanted to see our potential cancer patients within 2 weeks because we don't want to delay any of their pathway. So anybody who had a worrying symptom was still seen within 2 weeks, but things, for instance, patients worried about cosmetic problems, breast reduction referrals, breast pain referrals were parked. And so we had a backlog of quite a few patients who we parked. And now we're beginning to open up the clinic. So we just did a morning clinic and saw new patients with worrying symptoms, and that carried on as normal as triple assessment. And now we're doing afternoon new patient clinics as well to try and work through the backlog and get us back. We're still seeing all our urgent referrals within 2 weeks. We've never stopped doing that throughout, really. The other thing that changed from a patient pathway point of view was cancer work became a little bit problematic for a few weeks, probably for about a month to 6 weeks, because we just did not know whether we were going to have any theatre capacity to operate on them. And we also didn't know the Christie, as our local oncology unit, what they could offer in the form of chemotherapy and radiotherapy. So to start with, we didn't know if we were going to have any operating, but our management moved pretty fast, and we've been working at 2 private hospitals, the Wilmslow Hospital and Spire Manchester. So in Manchester, the private clinics have really stepped forward and have been amazing, fantastic at coming on board and letting us operate in a nice, clean environment. So in actual fact, because we're not doing any cosmetic work or anything like that, we're actually doing pretty much all our cancer operating within 2 weeks, which is actually quicker than we've ever done it.
Well, that's really positive to know.
Yeah. There are some downsides that initially for probably about 6 to 8 weeks, we haven't been doing reconstructive surgery due to the increased risk of readmission for those patients, and not knowing whether we'd have the theatre capacity. But as of this week, we're going to start doing that as well. So that's good for me, and it's good for patients as well. Patients have been wanting it, but being declined, and having to have delayed reconstruction further down the line. So there certainly will be, again, as with other units, a backlog of patients who perhaps haven't had the treatment that they would have chosen in a non-COVID situation. So there will be, I'm sure, an excess of patients in the UK who need delayed reconstructions.
And for those patients at maybe other sites who haven't been able to get a reconstruction, are there any risks in delaying it? And also, what has changed that allowed you to start doing these reconstructions again?
You kind of have to think back to what are the reasons that we stopped doing in them in the first place, and it really was a fear of not having theatre capacity. So thinking, okay, if we're only going to have a limited theatre capacity, we need to get as many cancer patients sorted and operated on and cancers out. So that was the reason for stopping, due to fear of lack of theatre capacity. But now we have theatre capacity at the private hospital in Spire. And so we have the capacity to do the patients. We feel that now we should give patients the choice really of whether they want to have the reconstruction, and that attendant risk of potential small risk of readmission and potential small risk of getting a COVID infection as a result of more hospital admissions. I think it's a small risk, especially at the current climate, but certainly my feeling throughout has been to try and maintain cancer care for patients.
Yes. Anything that helping maximize the OR time that you have? Are you doing anything in particular with the way you're scheduling those patients, or how they're coming in, or the question, are they having to have any quarantine before they come in so you know they are COVID free?
Yeah. So we've been doing it probably slightly different to other units. I don't think there is a right way or a wrong way to do it. Like other units, trying to keep the number of visits as low as we can. So at the point of diagnosis and consent to treatment, we've been trying to put a Magseed in, so that they don't have to come back for another visit to have a Magseed put in. Is probably, the first thing that we've done. Save them time.
And you're operating out of a cold site at these two private hospitals. How are you checking that the patients don't have COVID-19 before their operation?
They have a questionnaire at pre-op going through symptoms, and then they all being tested for COVID before admission. We have had a few asymptomatic patients test COVID positive, but then had the surgery delayed by a couple of weeks. And then again, on the day of surgery, the patients have, temperature checks and symptom checks to make sure they're happy to go ahead. And then in the post-op period, the breast care nurses are ringing the patients and checking that they have no post-operative COVID symptoms. And that's worked for us. I know the COVID test is not perfect, but they're probably low-risk patients, most of whom are self-isolating at home, to be honest. So I think the risk of having COVID has been low. I think we've probably had 3 COVID-positive patients picked up on the test.
The changes that you've had to make over the last few weeks have come from, I guess, you as the NDT discussing what's possible, what needs to change. How much are you picking up from other sites around the country of things that they're doing that you have thought are good ideas and want to implement? And how many other sites are contacting you asking how you're handling things and trying to learn from you?
Certainly the guidance from the APS has probably been the central pillar that we've based things on. We've certainly made our own discussions about the pros and cons of things that they've suggested, but most of what they've suggested is inherently very sensible. And then we've just really decided, as services could potentially come back on board, when to reintroduce them. So I think there's been a lot of chat between us and local surgeons about what are you doing with regards more complex breast surgery, what are you doing with regards radiotherapy, what decisions are you making about putting patients on letrozole. And I think it's just been a slow process of, once we can get treatments back to normal, we've put them back to normal as quickly as we can, really. Certainly quite early on, we could offer fairly normal surgical options apart from reconstruction. And as of about 3 weeks ago, we had full radiotherapy, chemotherapy options back on the table for patients. So it essentially meant that patients could go back to deciding what operation they wanted without any complications as to whether they'd receive their adjuvant therapy. I think for the first 4 weeks, it was very complicated, as we didn't know whether patients would receive their adjuvant radiotherapy or chemotherapy. It was an unknown, which makes for very anxious patients, and very difficult for them to make decisions when they don't actually know what the outcome is going to be. And lots of toing and froing, Matthew, with a decision being made one day to say, you can't have radiotherapy, and then maybe the next day it might be, oh, you might be eligible for radiotherapy, but the next patient isn't. So there was lots of toing and froing. So I think things are a little bit more certain now that we have open access to our normal services. So I think we're lucky in that way in Manchester.
Yeah, that is great. Are there any considerations for patients having adjuvant therapies in this climate? Are there any risks or ongoing risks of changing their or increasing their risk from COVID from having adjuvant chemotherapy or radiotherapy?
We've certainly been careful with our elderly, infirm patients not to expose them to a hospital environment if we can. So the really infirm ones, we probably are putting on neoadjuvant letrozole and just letting the COVID infection rate drop before we operate on them. Patients who need adjuvant therapy, essentially it's a risk stratification. So those that need chemotherapy, if they're high enough risk, they will get it. If they're a moderate risk, then they definitely have a discussion about pros and cons. Is it worth having? What's your risk of COVID infection? Because obviously, as you know, if you get a COVID infection during chemotherapy, it may be more serious.
Tony, from your involvement with the British Society of Breast Radiology and thinking on a more national view, when this screening service does get up again, or back up and running again, there's going to be a lot of challenges from capacity and social distancing and taking sort of old infrastructure of tiny waiting rooms with not much space to have 2 meters between patients and adequate PPE for all of the nurses and radiologists that are going to be helping that screening program get up and running. What do you see are the biggest challenges to that? And do you think that you're going to be able to cope with the backlog that is inevitably going to be there?
Obviously, I'm keen that we get up and start rescreening as soon as we safely can. But I mean, you've already alluded to some of the issues that we face. In common with most other screening programs up and down the UK, we struggle to maintain the 3-yearly round length. Now, clearly, if we're going to be socially distancing, we're only going to be allowing one client onto the screening van at a time. There may well have to be some sort of physical barriers erected. It's a headache, and I don't think anyone's got the answers yet. Now, there may have to be some hard decisions made. We may have to stop the age extension trial, for instance, or suspend it. Or we may have to further restrict the age group that are invited for screening. I think there are a lot of options, and I don't have the answers to any of those, but I know there's a lot of problems that do need to be overcome, and I think it's going to be a significant length of time before any program is in a position to start rescreening numbers in any large numbers of patients again. What we are doing, though, is we are starting to screen the high-risk women. That is, by NHS BSP standards, the very high risk. So these tend to be patients with BRCA1 or BRCA2 mutations, for instance. So we are starting to screen those, but they're relatively small numbers, and we can do those here within the Nightingale Centre. But population screening, I think, is some way off yet.
Of the 55,000 cases of breast cancer in the UK each year, what percentage of that come through the screening program?
It's about a third of breast cancers that are diagnosed come through the screening program. So, a large number, and clearly we want to get back up and diagnose as many cancers through screening rather than waiting until it presents symptomatically as possible. It's just the practicalities of how you do that. It's a big problem. And of course, what we don't know is how the prevalence of COVID, of coronavirus within the population is going to work out in the next few months, because that's going to be very critical as well. It does seem as though, from what one reads in the medical press and the popular press, that it's likely that we're going to be living with coronavirus for probably several years, if not, longer. So I think we're going to have to, whatever measures we introduce, I think are going to be long-term ones. There's some hard decisions going to have to be made.
Yes. That 1/3 breast screening versus 2/3 symptomatic. Is your ratio slightly different there because you're a referral centre for screening patients? Do you have sort of an even split, or?
We're 60% screening.
Yeah. So we cover a big. Our screening patch is bigger than our symptomatic patch, effectively. So that was a national figure of about a third coming through. There's about 18,000 picked up nationally by screening, and the rest of the 50 and a bit thousand are diagnosed through the symptomatic route. You
have put a lot of effort to make sure that you have all the right facilities for patients to be able to come in and be treated as best as they possibly can. If the restrictions are lifted tomorrow, there's still going to be a number of patients that are going to be concerned about coming into the clinic, coming in to see their GP, or having any interventions. It'd be great to understand from each of you what you think is important to tell those women about what you have in place, the inherent risk for them, and things like their treatment options. As far as patients visiting the centre are concerned, we do our utmost to keep it a clean, COVID-free unit. We're separate from the main hospital. We clean equipment between patients. We wear appropriate protective equipment. I don't believe that coming for a visit as an outpatient to the Nightingale Centre, or probably any other breast unit up and down the country, is actually any more dangerous than going shopping for half an hour in Tesco. So I think the message to patients is, we're here, we're open for business. If you've got concerns about your breasts, if you're worried, then get in touch with your GP, and if appropriate, your GP will refer you to us, and we will see you.
I'll probably add something else to it. From a patient's perspective, we as breast clinicians are a little bit limited in what we can do without Tony and his team of radiologists. So if you have a breast problem, nobody is going to be able to tell you whether it's okay or not unless you actually see somebody in person, and you're going to live with that anxiety of is it something or nothing until you come and see somebody. So my advice would be, I agree with Tony that I think you're lower risk coming into a place where everybody's wearing masks and is very well aware of what they're doing in infection control, and having your examination, your radiology, and hopefully you're all clear. And then you can just get rid of the anxiety rather than sitting at home worrying about COVID, worrying whether you've got a breast cancer. Just come and get it checked. And for most places, they are still going to see you in a timely fashion.
Many patients come along to the Nightingale Centre or to their local breast centre worried that they may have breast cancer. I'd just like to reassure women that the chances of actually having breast cancer are actually quite small, and only about 1 in 20 women who come presenting with a new symptom to our clinics turn out to have cancer. Virtually every patient with breast cancer is treatable. So if you do have breast concerns, then do go and see your GP, and don't be afraid of coming along and getting it properly checked out. We think of nurses and radiologists, surgeons, the support staff in the OR as
the professionals that they are, but also they're people and concerned about being in a hospital as much as anyone else, I would think. But they probably had to pull together and do a heck of a lot and to help look after these patients that are still coming in.
As a general rule, most healthcare workers are really proud to help with COVID and don't find coming to work a hardship in any way. That's the reason we're here, and that's the reason they enjoy coming to work. I think what most healthcare workers have struggled with is the implications on their own families of when they come into work and the children aren't in school. I think that's where certainly our colleagues are struggling, leaving small children at home when they're not going to school, trying to get home in time, children being anxious because of COVID and parents being away. So I think the sacrifices being made really are at home for most healthcare workers. So yeah, just from me, a big thanks to everybody who's putting those efforts in, and to the kids as well, because I think they're the ones being put through it more than mums and dads, to be honest.
Certainly, our some of our staff have had to rise to the challenge of looking after patients with COVID. Our healthcare assistants have been redeployed to the COVID wards, and have gone along cheerfully to do that work. So people have had to be flexible and to swap roles and to muck in where needed, and everyone's been really good at doing that.
I'd say the other big difference for me is that the NHS tends to be a very slow moving behemoth, really, and things don't change fast. So it's been quite nice in a way that every day there's been a change, and I think NHS management have been really receptive in allowing and facilitating fast moving change that normally might take years. But in fact, we've moved to private hospitals twice. We've moved Magseed machines about. We've moved all sorts of machines and protocols about from hospital to hospital, and it's all been facilitated. So I think that's been a real positive change.
Yeah, that was impressive how quickly the independent hospital network was set up and utilised by NHS hospitals. That was unprecedented, the speed at which it moved.
You also have to give thanks to the private hospitals for putting themselves forward, for it in supporting, because I'm sure they will have a massive hit on their income and profits.
Yeah, I think they're providing it at cost, aren't they?
Pretty much, yeah.
There are some definite positives to come out of this, and hopefully some things that we as a country, but you as healthcare professionals will now know that you can do as an organisation, whether it's as a breast care team, as a hospital, or as a trust, that I hope will carry on.
Yep. Yep.
Well, thanks for all you're doing. I mean, I know you said your piece about healthcare workers, enjoy coming to work and helping people, and that is clear. But
and getting out of the house, Matthew, it's very important. We have the privilege of getting out of the house.
Yeah, you're doing it for that cycle in the morning, aren't you?
Yeah, it's a blessing.
It really work from home long term, that's for sure.
Hey Tony, you got retirement coming up. What are you talking about? You'll be working from home for the rest of your days.
I keep putting it off.
Well, stay safe, both of you, and thanks for the time.
Thanks, Matthew.